बात ठीक है?
Assalamu alaikum everyone. So on behalf of Comstech, I welcome all the distinguished speakers and participants for this workshop on International Seminar Challenges for the Healthcare in Pandemics. So we will start off with the tilawat. I'll just play a video.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الرحمن علم القرآن خلق الإنسان علمه البيان. الشمس والقمر بحسبان والنجم والشجر يسجدان. والسماء رفعها ووضع الميزان ألا تطغوا في الميزان وأقيموا الوزن بالقسط ولا تخسروا الميزان. صدق الله العظيم.
Jazakallah. Now I would request Dr. Muhammad Sadiq Ali Khan for his opening remarks. He is Associate Professor at University of Karachi and he'll be the moderator for today's event. Dr. Sadiq.
A'udhu billahi minash shaitanir rajeem. Bismillahir rahmanir rahim. On behalf of the Comstech and IEEE Karachi section educational activities, I welcome you all, the participant here in the international seminar on challenges for the healthcare in pandemics, organized by Comstech in collaboration with IEEE Educational Activities Karachi section. The pandemic opens new dimension of thinking in every walk of life, especially our healthcare industry, which now requires new ways of working, new method of communication, finding new solutions to problems, and trying to innovate the solution. Digital health in the current era is more than just online virtual visits and distance patient monitoring. The COVID-19 pandemic primarily redesigned the healthcare system and highlighted the important gaps that can be problematic in the future. So in today's seminar, we have 4 distinguished international speakers. Professor Andrew Weir from University of South Wales, and Professor Morris from Ulster University, United Kingdom, and Professor Jim Buckley from University of Limerick, and Dr. Wassa William from University of Science and Technology, Marlborough. First of all, I would like to thank Professor Dr. Muhammad Iqbal Chaudhry, Coordinator General Comstech, Sitara Imtiaz, Hilala Imtiaz, and Tamga Imtiaz. He's also a director of ICCBS and Professor of Bioorganics and National Product Chemistry. Professor Chaudhry has since 1990 been among the world leaders in the field of natural product chemistry and has made pioneering contribution in the discovery of novel natural products. His contribution to reverse bacterial resistance to antibiotic represents seminal contribution in this important field. He established several research centers in Pakistan and helped to set up research unit in Africa and South and Central Asia. His scientific and capacity building contribution have been recognized by prestigious national and international scientific and capacity building, and he won recognized as several awards and honors. He is a distinguished national professor. Professor Chaudhary has more than 11,075 publications. His citation above 27,000 and H index is 68 in the field of organic and bioorganic chemistry, along with 57 international patents, 76 books and 40 chapters in books, published by major US and European press. On the basis of his research, 87 students have been awarded PhD degrees. Apart from this, Professor Chaudhary is providing technical support and guidance to various industries of Pakistan. He is our national hero, and I would like to welcome Professor Dr. Iqbal Chaudhary for his welcome address. Sir.
Bismillahirrahmanirrahim. Good morning to our friends in the West, and good afternoon to very distinguished speakers and guests in the East. Professor Sadiq, thank you very much for a very generous introduction. You've been so kind. He has been an extremely important member of the Comstock family, regularly organizing these extremely important events, which touches some of the most important topics addressing the current issues in the country. Our partnership with IEEE, being the largest professional organization of the world, has been extremely fruitful, and we have organized lots of events in the past also. Comstech, as he mentioned, is Pakistan's strongest intergovernment organization with 57 ministers of state, and this is largely OIC's instrument for science and technology cooperation. Been very fortunate to have distinguished national professor and a very dear brother, Professor Dr. Shankar Bhavani Chaudhary. He has been one of the most prominent figures in furthering and forwarding the agenda of science and technology in Pakistan and in the region also. The topic is extremely important, and we have seen that this year 2020 was remarkable in every definition of the world. We have seen people dying. Over 3 million people have already died, or a very large number of people, over 300 million infected, suffered comorbidities of different kinds. And there has been a gross loss of economies all over. There's an estimate that the economic loss of this pandemic, as the situation unfolds, would perhaps exceed to $50 trillion. And as Melinda Gates says, that any calamity of this magnitude magnify the differences and problems which already exist. And that has exactly happened. The difference between the haves and have-nots have increased. We have seen the systemic racism increase also. We have seen lots of things which were there before has been magnified in a much larger canvas. And we have seen countries literally melting down. Their economies have melted out, and we have seen a gross misery of humanity. Seems to be all gloomy, but if we look into what science and technology has done in last 1 year, been truly remarkable by all definition also. Science and technology has exceeded to the global expectation. When everything failed, global cooperation, economic cooperation have failed, and other international cooperation have been miserably failed, science and technology delivered. And we have seen that from detection of the biological understanding, development of diagnostics to vaccine, everything has actually happened. Technology has fulfilled all the promises which it has made to humanity at large. And if I see post-COVID world, if there is anything like this exist, then technology would play an extremely important role. Pandemic. This is not the last pandemic. It is perhaps one of many pandemics which will come forth, and we need to have resilience and preparedness for the next health challenges. Topic is extremely important and certainly the one which would require lots of brainstorming. I'm absolutely delighted that these efforts are led by Professor Chaudhary, who is a dear friend, a very competent and great leader in terms of moving forward uh, in fostering technology and mentoring young people. With this, I would like to welcome all of you and especially our very distinguished speakers who are, I'm sure, especially making efforts to participate in it because of the time difference. I can see people from different countries and their participation is greatly appreciated. With this, I would like to thank all of you and wish you a very fruitful and meaningful event in next few hours. Thank you very much.
Thank you, sir, for your kind words. Now, I would like to request our honorable chief guest for today's event, Professor Dr. Bhavani Shankar Chaudhary, Izaz Fazilat, and he is HEC Distinguished National Professor, Member Board of Governors Higher Education Commission, Professor Emeritus and Advisor to Mehran University of Engineering and Technology, Coordinator European Union Central Project of Mehran University, and former member of governing body of Pakistan Engineering Council. He is currently the chairman, Karachi section IEEE, and former member board of trustees Pakistan Science Foundation, and he is a lead person in the European Union on different projects of European Union regarding the Mobility for Life, InTech program, and CAPRO Strong Leaders program, and he is a national distinguished professor. So now I would like to request Professor Dr. Bhavani Shankar Chaudhary to say his words.
Thank you very much, Professor Dr. Sadiq Ali Khan. First of all, very good morning, good afternoon. I'm really humbled with the introduction and the words, kind words, Professor Iqbal Chaudhary has mentioned about me. Really, it's all teamwork, and I know in short span of time, Dr. Sadiq Ali Khan, with the collaboration of Comstech, really we got such a big, marvelous platform to get such a wonderful speakers all around the globe. And Professor Iqbal Chaudhary already mentioned that this is series of events. Even the workshops, technical trainings have been conducted, and the participation. It's always difficult. Every place webinars going on, and then we always like a transistor is shrinking. We see limited participation. Even 2 weeks back, we had one European capacity building workshop on new product design and development under the master's program DTBT, Digital Technologies for Business Transformation. Though we have got 3 European universities, 6 Asian universities, altogether more than 250 registered, but at the time of workshop, there were around 40 to 50 participants. So I always appreciate the collaboration. It's because of the Comstech support and Dr. Sadiq Ali's effort that he always how to get maximum benefit from these events. He knows all those tricks of the trade. And it's always good to see the old friends. Andrew Ware, I traveled last time with him. We were in Islamabad, traveled today in the flight, and I was on one seat, he was on the other seat, and in the middle seat was the famous our singer, she performed what's name, Sania. She performed actually on Women's International Day in President House, and we had such a wonderful discussion. And of course, he was a keynote speaker next day in conference at University of Karachi, organized by Sadiq Ali Khan in technical collaboration of IEEE. And Jim belongs to UL, many friends, University of Limerick. I'm grateful that since last 4 years, I am one of their external examiner on undergraduate, masters, and some of the PhD thesis as well. So it's really a lot of learning and sharing about the technical knowledge, and this as Professor Iqbal mentioned, pandemic, we have whole world has been suffering, and this is the technology which has brought the vaccine and all these things, and the efforts of scientists. And IEEE has been contributing for this cause in many ways. Even two of members, they applied for more than $5,000 funding for small projects. They have been funded by IEEE. So IEEE headquarters. So there have been many calls, those who have been attending, the participants. Really, there are many opportunities under the IEEE platform, especially nowadays, to get funding for COVID-related humanitarian technologies, or we call it epics engineering projects in community services. There have been call every 3 months, 6 months. So I encourage people to apply for such projects, because COVID has impacted a lot to every walk of life. And I think the experience we will learn from learned speakers, I think that will go long way. I'm sure those lectures are being recorded, and I think we can share that under comstech and IEEE platform in academia as well, in hospitals, I mean the medical universities, so that such knowledge could be shared. We can have a special link, and I would request Dr. Sadiq Ali Khan to share, because he is also heading education activity chair of IEEE Karachi section very actively. So I'm again grateful on behalf of IEEE Karachi section. I'm highly grateful, indebted to Comstech, Professor Iqbal Chaudhry, and the speakers for giving their valuable time for such a good cause. And definitely all the participants, and our country, our nation, I think whole world will benefit from such a wonderful talks. Thank you once again.
Thank you, sir, for your kind remarks. So our first speaker is Morris Malvina. He is serving as a professor of computer science at Ulster University. His research areas include computing and mental health, artificial intelligence, digital well-being, innovation, and assistive technologies. He has been a principal investigator in around 50% of over 150 international research projects. Arising from his research, he has published over 400 papers and served on numerous program committees. He also a co-chair of the 32nd British Human-Computer Interaction Conference in 2018 and co-chair of both the 31st European Cognitive Conference in 2019 and the 5th IEEE International Conference on Internet of People in 2019. He is a senior member of both the Institute of Electrical and Electronic Engineering and ACM, and a chartered fellow of British Computer Society. His title of the talk is Digital Mental Health and Wellbeing Interventions, Analyzing Interaction from Apps, Conversational User Interfaces, and Telephony Healthness. On behalf of the Comstech and IEEE Education Activities Karachi section, I welcome you, Morris. Thank you for your precious time. So now Mike is hand over to you, please.
Thank you very much, Dr. Khan, and thank you very much for the very kind welcome from yourself and from both Professors Chaudhry. It's very much appreciated to have this invite to to speak to the IEEE Karachi section and to the group in Comtech, and to all the people listening from around the world. It's a great opportunity, and I'm very appreciative of it. And thank you for facilitating my schedule. It's very much appreciated. So the talk is about COVID, but not maybe directly, as you'll see from the start. Let me just see, I presume you can see my slides. Please let me know if you cannot. So the three areas I'm going to talk about in the next 30 minutes are, it's all about data, really. It's about moving from a medical engagement with healthcare professionals, adopting the use of digital interventions, and any digital intervention generates lots of data. Now, whether it's an app, and the app I'm going to talk about is for people living with dementia to be able to accommodate their memories, and whether it's an app or whether it's a different kind of an app, a chatbot, which is a conversational user interface, or the third area is helplines. So we know that the helplines are an important low-cost way of supporting people's mental health around the world. And indeed, the International Association for Suicide Prevention president is from Pakistan, the global president of IASP. So across the area of mental health and well-being, myself as a computer scientist, I'm very interested in supporting this area, but my selfish interest, as is any engineer, I think, is to access data and then to understand behavior from the data. So the first area that I'd like to talk about is apps, and the app in particular here is what we call a reminiscence app. So this has been funded by our Department of Health for us to design it and build it following research where we showed that it was an effective intervention. So interdisciplinary research working together with nursing academics and computing scientist academics to develop this app. And here we've got some nice photographs of Ireland. So Jim, our next speaker, is in the southern part of the island, and I live in the northern part of a very beautiful island, different kind of beauty from Pakistan. It's always green because it always rains. But sometimes the sun comes out and we can put photographs onto our app, and these photographs can help us remember best times and weddings and family occasions and so on. And this is the app, and we've published research in this, and the papers that I have at the bottom of some of the slides are also listed at the very end of the slide set, and I'm very happy, Dr. Khan, for you to make these slides available to anyone who's attending the talk. But as I said, we have a selfish interest, which is the data. So people using the app generate data. Now, it is anonymous, so it isn't invading their privacy. We do know whether they are flagged as a carer or a PWD. Here means person with dementia, person living with dementia. So even very simple things such as when do they use this app starts to become revealed. So we see that down in the bottom left, the turquoise green color in the small hours after midnight, 0001, 02, 03, show that people with dementia aren't sleeping. They are using the app as an alternative to sleeping. You can also see the shape of the curve through the day. So there is a peak before lunchtime, and then as people are eating, there's less usage, and then it increases in the afternoon, drops off at tea time, dinner time in Ireland, and then it peaks again in the early evening. So we can get for the first time actually, what are people's behavioral patterns in their usage of a digital intervention. And this is quite new. Remember beforehand, if you wanted to see where people with dementia reminiscing, you would have to knock on the door after midnight, of your grandfather or grandmother, and it maybe waking them up just to ask them that question. So here we don't have to intervene, we get that data. We can also, in the abstract for the talk, I talked about the data as a kind of a digital phenotype. So it's a way of identifying the person by their digital trail. So I'm not going to spend too much time on that. It's an interesting area, a growth area, mostly in psychiatry and psychology, where apps are used to gather data, which people, clinicians, consultants can then use to assess the digital phenotype, the behavioral profile or fingerprint of users. But here we're just interested in more raw data initially. But we can also do something called ecological momentary assessment. So many times when you've been using an app or a website, it pops up with a question, maybe asking you to fill in a survey or just asking you to rate the website or the app on a scale of 1 to 5. And all ecological momentary assessment is the scientific, psychological, academic perspective of that technique. So we can ask people how they feel. We can ask them how well reminiscing is going. You can ask if you're designing a study, you can have primary outcome measures, and you can put some questions relating to the primary outcome measure in these pop-up questions. So here we're seeing the number of questions presented again for the caregiver and the person living with dementia. And you can see we've analyzed in the paper, which you can click on in the link when you have the slides. You can see the response rate. And we know from analysis that 8 o'clock in the evening has the highest response rate and the lowest dismissal rate, because people can always dismiss these questions because they don't want to answer them or they don't understand or whatever. So 8 in the evening on a Tuesday is the best time to ask someone a question if you want to get an answer. This is people living with dementia. So again, we're finding stuff that may be of interest in a broader area. But as well as just getting data and statistics, we can also do machine learning. So this is when it starts to become interesting. So here we're using k-means clustering. This is a PCA, principal component visualization. You can see 3 clusters quite easily. The big clusters with some overlap between them. And then there's a 4th cluster very much up in the top left. So this was a small sample size, and this single cluster in the top left is an individual who was a high volume user of the app. But you can immediately go from the data to some machine learning, and then you're understanding behavioral patterns. You can label these patterns, and then you can monitor them as a researcher. So not only are you developing an app for the people to use for their own benefit and their health and well-being, but you're also getting insights, which gives you evidence to justify continuing funding for this kind of research, and that's very important. So the app was formally launched just in the first day of this month, the 1st of March, and it's free to download worldwide on both Apple and Android stores. And please do try it out. Google the Inspired app and you can find it, and you can see the science behind it at these papers as well. So here again is just the box plots of the different clusters we have identified. So you can see that there are 4 clusters identified. If we look at, say, the top right box plot, we're seeing that cluster 1, 2, and 3 are relatively similar. So each of these box plots describes the clusters through the lens of a variable. So the top right variable is the number of carer interactions with the app. So this is a cluster. There are 4 clusters. 1, 2, and 3 are quite similar in terms of the number of carer interactions, but the 4th cluster is quite different. So we would automatically know that 4th cluster we would label it something like high care interaction. And we can do the same for each of the clusters. If we look then at the bottom left cluster, we can see that there are again 4 clusters. And the variable here is a standard deviation of the intervals between each unique day interaction. So we're deriving a variable here, which is a standard deviation, looking at the unique day interaction. So if someone's used it for a day, that counts as a unique day interaction. So here we're seeing 4 clusters. Actually, cluster 1 is strange, but it's the one with just one person in it. But cluster 2, 3, and 4, cluster 3 is quite different there. So you can see that we can go around the different clusters that we've automatically identified using k-means, and we can derive names for these clusters, labels. And then, of course, we can use that in our research going forward. So if we find out that, if there's 10,000 users of the app in a year's time, and we get this kind of cluster behavior, we can improve the design of the app to cater for these different groups of users. So I think you get the idea, hopefully, that the value of data here, and then the value of data analytics of this data. So that's the first one that I wanted to talk about. And by the way, this app is available, and it's very important for people with dementia during the lockdown in Northern Ireland and the UK and Ireland. So people have been using this because they can't go out, they can't visit friends, so they can download information, and we're gathering the data about the usage as people are in lockdown. So indirectly during COVID, we're getting data about the behavioral usage as people are staying at home more. This second case study source of data is about conversational user interfaces, or these are also called chatbots. Now, there are many chatbots out there in the wild. Many of them are also backed by research. So Wyza, Uper, Wobot, IonaMind, there are many, but there is one that we are developing as part of our research to focus on those people living in northern fringes of Northern Europe. Northern Finland, Northern Sweden, Greenland, Iceland, Faroe Islands, Donegal in Ireland, and the north of Northern Ireland. So the funding is specific for these peripheral areas of Europe, and to help people who have maybe a 50-kilometer journey to travel to a health center or whatever, and a chatbot can help support them as part of a blended service. So it's not just face-to-face, it's not just digital, it's face-to-face backed up by digital, and this is important. So in the UK, an organization called Orca has been funded by or contracted by the National Health Service in the UK to validate apps so that the apps are fit for purpose. So it's kind of like an assurance license. And this heat map shows over time on the x-axis and different categories on the y-axis what is important to people. Now, there was some searching for COVID-19 information in respiratory conditions, some on diet and fitness, but the main thing in the middle of the 2020 was search on mental health. You can see this this dark bar going right across the timeline. So this was something that people wanted, and we responded to this. We developed, along with Cork Institute of Technology, now Munster Technical University, and charities that work with people in supporting their mental health, such as Action Mental Health. So we worked together. It wasn't just computer scientists. It's very much an interdisciplinary work like the last one. And we've developed ChatPal. And this is just a tool that allows you to have a conversation. And this could be it's going to be translated into Finnish, into Swedish, into Scots Gaelic, and it's in English, and it could easily be translated into Urdu or Pashtun or other languages. We have designed it so that it can be used in different areas. And the whole design is based on a positive psychology perspective. So it's not for people who are mentally unwell, significantly unwell. It's for people who want to support their mental health and well-being. So we all feel a little bit stressed, a little bit anxious, a little bit depressed sometimes. And this tool is to help you try to reflect on that and to posit a more positive outlook on life. So it just allows you to chat just like a Facebook Messenger or WhatsApp or whatever. It allows you to chat, but you're chatting with a computer, you're chatting with some artificial intelligence. Now, I haven't got the information on the slides, but there is an open source chatbot development framework called RASA, R-A-S-A, and we have developed using this again because we didn't want to be on any proprietary platform. We wanted this to be an open source installation that anyone around the world could download after we've finished developing it and then customize to their own language and install for their users. And we developed this because we spoke to a lot of mental health care professionals. We asked about, so these are people like nurses in the community supporting people's mental health, consultants in the hospitals and in clinics, and psychologists who are providing support services to people. So we asked all of those people across Finland, Sweden, Scotland, Ireland, Greenland, and so on, you know, what you would use a chatbot for. And you can see that the blue and the green here are some potential, significant potential. So what was really interesting was that apart from the very bottom one, diagnosing, most people believed that there was some or significant potential in self-management, education, training, counseling, cognitive behavioral therapy, and screening. So it was seen as a tool that wouldn't really diagnose. You know, if it got it wrong, that would be pretty bad, but it could do all these other things, and self-management was the key one. Actually, screening is pretty high as well. So it could help people to see, you know, am I really unwell, or and perhaps realize that maybe they're just having a bad day, but maybe they are having something that needs the access to a professional face-to-face, a human being. So this blend of services is really important in our view. So yeah, so on the island of Ireland, working together with people in Cork and Belfast, we decided to bring forward the development of this, and we launched it in mid-2020, whenever the first lockdown was down. So it was a concerted effort to get this available so that people in lockdown could use this. But also, and I don't have the analysis here, it's too soon, but just as we have done, and I've shown some data and then graphs and then machine learning for the reminiscence app for people with dementia, so too are we also doing this with this app. So we will have anonymous usage data, and we will be able to carry out machine learning on usage data and so on. So this is very exciting for us as well, with these two apps in the wild. And these are apps that the health service is interested in because it is less expensive to offer this, and it spans distance more easily, which is very important. So the third area that I want to talk about is helplines. So as I said already, the International Association of Suicide Prevention president is based in a Pakistan university, and we've been working with that organization and others, and this is absolutely specific to COVID-19, the pandemic. But just as we're doing in this case study, talking about the impact of the pandemic on the helplines, so too can we do the impact of the pandemic on app usage. But we haven't prepared anything on that. But this one shows you the difference that the pandemic has. And it actually took us into a very new area of research, which was what effect, you know, what is the impact on the helpline of a major societal effect in society? Now that can be a pandemic, which is like a long, slow, significant effect, as we all know. In the UK, we have 126,000 deaths almost. In Pakistan, I think you have a tenth of that, around 16,000, and every death is significant. And across the world, we have very large numbers of people being affected. So this case study shows you the effect on a helpline by people and their calling of the helpline. And this is based on data on Samaritans in Ireland. And the time scale we're looking at, Samaritans is a national lifeline for people who feel stressed, anxious, depressed, need to check in and talk to someone. So there's an emotional support function. There is also a suicide prevention function. So the counselors, the volunteers who answer the phone, whether it's in Pakistan or Ireland or US or Mexico or South Africa, they often give their time freely, and they're trained how to counsel the person and not be judgmental. So we looked at we have access to all of the telephony data. Now, this is not the content of the calls, but it is the time of the call, its duration, and a hash code for the telephone number. So we don't know the number, but we know if the same number rang at different times. So with just that data, we took that data for 2020, and we looked at in Ireland, we have the National Day in Ireland of St. Patrick's Day on the 17th of March. And in the UK, there's a famous horse racing festival called the Cheltenham Gold Cup. And really between the 17th of St. Patrick's Day in Ireland and the Cheltenham Gold Cup on the just around then, the lockdown, came in. You can see there's some detail here about the announcement of the lockdown was announced on the 12th, and it really only businesses were closed on the 24th of March. So just a year and a week ago, when the first lockdown started. So we took the data from the pre-lockdown February, and then we took the data from April, which we call active COVID. So we were looking at before the lockdown, and then the impact of the lockdown had just come into effect. We then looked at the data in 2019 as well to make sure that there wasn't some kind of more calls in April, anyway, regardless of what year it was, and we saw that there weren't. Now, here we have a little animated GIF, and I take a few minutes maybe to describe this. This is called a density plot, and this is a density plot of the call duration. And you can see the scale, the x-axis is goes up at a log scale. So we've got 10, 100, 1,000, 10,000, and that scale item is seconds. So you can see that there's a kind of a peak just under 10 seconds, and there's a biggest peak at about 1,000 seconds, which is around about, from my maths, about 15, 16 minutes. So we're getting two peaks in the data, one at about 16 minutes and one at about 4, 5, 6, 7, 8 seconds. And what those peaks are, in effect, are traditionally some people call for just a check-in call. They might just call and just say a few words and then hang up, or they might need emotional support and be on for 15 minutes or longer. And you can see the tail off towards 10,000 seconds. And so this animated GIF goes from the different week numbers. It starts there, and then it's moving. And as time goes on into the pandemic, we see that the number of short calls drops off, and the number of longer calls, 15-minute around then, starts increasing. So, here's the before and after, just in a slightly different plot. But so we're seeing all of the pre-COVID month, February here, and we're seeing all of the active COVID month, April here. So you can see that the pre is the red, and there's quite a lot of snap calls or check-in calls. Whereas if we look at the active April calls, we're seeing that kind of collapses, doesn't disappear completely, but it does collapse. And most of the calls are for longer periods. So, and why would this be? Well, we'll talk about that in a moment. Now, incidentally, I didn't put in the slide because I didn't think I would have time. But if we look at just the people who called, and we can do this because we know the hash code of the telephone number. If we look at those people who didn't call until April, so they only started calling the Samaritans ever, and we can go back to 2013 to check this. So people who never ever called the Samaritans until the active COVID period of April, there is no snap call, no short duration calls. It's straight in long calls. So we can take the longer calls as a proxy for people in more need in society. So we're seeing that a major societal event has an impact. Now, I'll just say a few words about other impacts. Now, Jim will know in Ireland. So we know in places like the US where there are mass murders in high schools and so on, very traumatic events. We also know that there are terrorist events all around the world, and few countries are spared. In Ireland, we're very grateful now to have peace, both north and south. However, we're still getting traumatic effects in society, and in Cork County in Southern Ireland, in the past 6 months, there have been 2 murder-suicides where both in agricultural, where a farmer, father and sons have fallen out, and one has killed the other 2 and then taken their own life. So they've committed murder and then they've taken their own life. So we looked at those events as well. And we found this kind of impact of a change based upon society, trying to respond to that by calling helplines. So we hypothesized that we would be able to do this around the world. And indeed, whenever the comedian and film actor Robin Williams took his life in 2014, all the helplines around the world recorded increased numbers. That's why it's very important not to reveal information in the media about methods of suicide and so on, so that people don't, who are similarly depressed as a result of reading about that, decide to take their own lives and see that as a valid technique to do it. So we also did machine learning, k-means clustering across these different data sets. We've been doing this for years with the Samaritans data. We know that if we take a data set of 2014 and do k-means clustering, and then take 2015 and do k-means clustering, we get the same behavioral clusters. We get 5 of them, and we've given them labels. So there are high frequency callers making hundreds of calls, quite short calls, and there are very few of them. This is a phenomena that is common around the world to emergency service numbers. So Pakistan, every country has its own emergency service number. And what you will find is that there are a very small number of people calling those numbers quite a lot of times. Now, for the Samaritans, these people, they weren't, the service is not really designed for this kind of caller. They have a need, but emotional support or suicide prevention support is not the need, and that's what Samaritans does. So something needed to be done to try and address these high frequency callers. So the machine learning identified these callers automatically, also identified other labels, typical callers, regular callers, unpredictable callers. Now the single lengthy calls, we made 1 or 2 calls on average, quite long, 30 minutes to 1 hour. And the most consistent call duration. So if they did call, they usually called for up to an hour. And these are the people that the Samaritan service was designed for. People like you and me, who maybe are getting on fine and something happens in our life and we just need to speak with someone else. And we are maybe in crisis and we ring the Samaritans. So those are the ideal use case, if I can put it in engineering terms, for the service that Samaritans offers. And the high frequency callers are not, but the volunteers still speak with them. But we found that in some helplines, maybe as few as 10 to 20 high frequency callers were taking up 40% of the capacity of the volunteers in answering the calls. So that meant that in practice, some single lengthy callers for whom the service was designed couldn't actually get through because the person they would have spoken to was busy speaking to a high frequency caller and trying to deal with their need. So again, the publication on this work is down below at the bottom. So we looked at the COVID period, and we looked at the change in these people over time. So you can see that just at the top of the graph, you can see it going through the different weeks. So it's about to start again. So 26, 7. So you can see that the high frequency callers at the start had a lot of snap calls, short duration calls. And then after, we looked at data in late summer and so on. So it kind of came back again, the snap calls again. If you look at the single lengthy callers over time, you can see that, apologies, these are in different scales, but you can see that at the start, if we wait until the start period again, look at the single lengthy, yeah. So we're seeing shorter calls and then a move towards larger calls and then a reversion to shorter calls, but still 15-minute is the shortest there on the single lengthy calls. So I won't go through each of those, but this is really valuable. And indeed, what we are now doing is working with them to build a dashboard and to automate the routing of these high frequency callers into a queue system. And we've found that if the high frequency callers are presented with a queue, then some of them persist to call, but most of them don't. And then that means that there's more time available for the single lengthy callers and the people in the emotional need. I've just shown it here, maybe in a more less animated way, but we can see the high frequency callers, and the red is a pre, and this is by hour of day. So this is a whole day. If we look at the top left, we can see the high frequency callers, and we can see that before COVID, the more calls at 5, 6, 7 in the morning kind of dropping off. And then for active COVID, the high frequency callers just across the day called more and peaked at the same time as the pre-COVID peak in the early hours of the morning. So these callers, we're beginning to learn something more about them. They're ringing up probably when they just get up, or maybe they're insomniacs or whatever. But they're calling a lot at quite an unusual time. If we look at the regular callers, we're seeing a change there, an uplift in the morning time only in active COVID. And we're getting that same behavior with the typical callers actually in the wee small hours from midnight to 6. And then the unpredictable callers, not really much change. And on this visualization, the single lengthy callers, actually some of the pre-COVID stuff is just peeking out there at around lunchtime, calling more in pre-COVID, calling less in active COVID. So we're finding out a lot of really useful information. To summarize that, fewer checking in calls. These are up to 5 minutes, typically smaller, and more emotional support calls. High frequency callers and typical callers tending towards longer calls. More of this happening in the midnight to 6 a.m. for most people. So this now shows us, going back to my point about Robin Williams and murder-suicides, which are very focused, events. They happen, media report them, but whether it's that or whether it's something more of a slow burn like a pandemic, we're seeing that telephony data is a lens. It's kind of reflecting rather the societal impact of these things by having more calls and changes in call behavior, and the different behavioral clusters that we know are stable in the data for this telephony data change, and we can learn an awful lot from that. We've also found that in September, we went as far as August. Sorry, we looked at February as pre, we looked at April as the main impact active COVID period, but then we looked at June and August, and we found that people started responding across all 5 clusters to typical behaviors. So this kind of hedonic adaptation, no matter what happens, no matter what gets you down, many people as a society, we all get together, and in crisis, we work together and beat whatever it is that's affecting us. So just to summarize in the last minute here, across these different areas, we've found that all of these generate data. This is digital phenotyping data, can allow us to have insights about individual users or aggregate behavior of different users using machine learning, can really reflect different behavioral clusters. And for the apps, whether it's reminiscing or mental health, that can give us real insights into usage. And for telephony, such as the helplines, that can really help us and actually turn and be put to use operationally. So to do all of this, if you're thinking about these kind of move towards digital in the east or west, we need to agree the healthcare professionals have to be part of co-producing the solution. It has to be something that people need and want, and then it has to be something that digital can do well. It can't just be something that's like a shiny new toy or whatever. So that's me. That's my talk over. Thanks to all of these people and organizations rather that have contributed, and all of the papers are available on my slides now. So thank you very much again for this opportunity.
Thank you. I have one question from Jim. He asking, what do you think can be done to address these pattern changes, that is freeing up this Samaritans?
Yeah. So
that helpline 126. I appreciate you may have to go now and cannot answer now.
I'll answer that one. So we operationalize that by putting in something called a automatic distribution queue, and it detects whenever one of the callers who is identified as a high frequency caller from the clustering calls a service, and as a result of that, then it routes that. It can route that call to a different kind of volunteer who is trained to speak with that call, and actually then it can ask them to maybe use other services. It can introduce new services and so on, but the objective is to facilitate those people to move to a different service and to free the volunteers up for the other people to use them. I hope that answers.
Thank you, Morris, for your valuable time and valuable talk. And hopefully we will meet again physically here in Karachi and Islamabad, Pakistan, after this pandemic situation comes normal. So
thank you very much. Thank you very much, Dr. Khan. Thanks everyone, and apologies I have to leave, but I will look at the recording, and I will email you to answer any questions that people may have in the chat or whatever. So thank you very much.
Thank you, Morris. Thank you. Our next speaker is Professor Jim Buckley. He's serving as a professor in CIS department as a principal investigator in Lero, University of Limerick. He is director of a €6 million research initiative in trustworthy and responsible software engineering, TREES, an initiative funded entirely by the industry. Furthermore, Professor Buckley is leading 4 industry co-funded research projects with a combined budget of over euro 1.3 million. He is also the author and co-author of funding with a total value of over 36.5 million euro to University of Limerick. In addition, Professor Buckley is a member of the 8-person SFI Expert Advisory Group on COVID-19 contact tracing for the HSE. So I would like to request Professor Jim Buckley for his talk. His title of the talk is Co-Vigilant Toward Optimizing Contact Tracing App from User, Best of Breed, and Idealized Perspectives. Now over to Professor Jim Buckley.
Thank you, Dr. Sadiq, and thank you for the invitation and the opportunity to talk to the IEEE Karachi section and Comtech. It's very much appreciated. And I also want to thank Morris. I realize he may be gone now to get his vaccination, but it's the first time I have ever heard my home county, Donegal, mentioned in an international conference presentation. So I'm very, very happy about that. Yeah, just to give you a quick bit of context about where I'm from. I'm from Ireland, as was Morris, a small island on the west coast of Europe, which looks out at 3,000 miles of Atlantic over to America. In specific, if we scale up a bit, you'll see that I'm in a place called Limerick, and indeed Morris is in a place called Belfast, which is up at the very top right of the map. And that trip between the two is about, I'd say, about 5 hours. So that's the scale of the country. And over on the top left is that place Donegal that he talked about, where I come from. It is, as Morris said, a really beautiful place with all the cliff and coastal scenery. So I just decided to put a few photographs in there as a sort of warm up to my talk. Yeah. So what I'm going to be talking today about is Co-Vigilant, and this is an SFI-funded, Lero-based COVID-19.
Dr. Jim, I don't know, is that screen fully appearing? On my screen, it's not fully appearing. Dr. Khan?
Yes, sir. On my side also.
Yes,
it is not appearing.
Shifted on the right, actually, so we can't see some portion of the presentation.
How about now? Is that better?
No, it's same.
Okay.
I don't know why it happened.
Let me try and do it from just, let me try this. Can you see it now? Sorry, you're on mute.
Yeah, sorry, it's perfect. Now you have to switch to presentation mode.
Okay, I might leave it out of presentation mode because that's what seemed to cause the problem the last time. So I will continue just as is. Okay?
Oh, perfect, perfect.
Okay.
Thank you for notifying me. Yeah, so I'm going to talk to you about Co-Vigilant, a project funded by Science Foundation Ireland, carried out in Lero, which is a COVID-19 rapid response project. So let's unpack that a little. Science Foundation Ireland is the national science funding agency, and Lero is a software research institute which is centered in Limerick. Last year, as part of the response to COVID-19, the SFI put out a special call for short-term COVID-19 focused projects that would help in our national response to the virus. And we were successful in obtaining one of those grants, and the project was entitled Co-Vigilant, towards optimizing digital contact tracing. So what do we mean by digital contact tracing? Well, digital contact tracing is the idea that everyone downloads an app on their phone, which then uses the signals between phones to track when they are close to other people with that app. So specifically, if you are less than 2 meters away from someone for 15 minutes and both of you have the app, that contact will be registered, a close contact will be registered. And then if one of us subsequently tests positive, all our close contacts can be alerted so that they can be tested themselves and isolate themselves. This has a big advantage because it's instantaneous. Once I am tested for COVID, the alert will go out to all my close contacts. And also it'll go out to close contacts I didn't even realize I had, like the person I was sitting close to on a bus that I don't know, or a guy I sit beside at a bench that I don't know. So it has definite advantages, and it is an integral part of our strategy to limiting the spread of the virus. Okay, just before I talk about the project itself, I want to talk about context. Specifically in the EU, we have something called GDPR, General Data Protection Regulation legislation. And all apps, information systems, and organizations need to be GDPR compliant. And that means that we must gather minimal personal data for the minimal time needed for its purpose. So only for the purpose that it was intended. So for example, we can only collect 14 days close contact data because the disease is only transmissible for 14 days. So we cannot gather 16 days or 17 days data. We gather minimal data and only for the purpose it was intended. So much so that even if I test positive, my close contact information can only be shared with our health service, called the Health Service Executive, when I am COVID positive, i.e. when there's a need, and even then only with my explicit consent, and for the last 14 days, because that's when I could have transmitted the illness. Another important contextual point is that Google and Apple stepped up to the plate and said, we're going to provide a service to you that will figure out close contacts. So we're going to use the Bluetooth low energy signals from your phone and others' phones to figure out when you are within 2 meters of someone else for greater than 15 minutes. That was great in that it freed up a lot of resources for our various health services. They didn't have to worry about figuring all those close contacts out. But it's also a double-edged sword in that Google and Apple only allow one health authority per national jurisdiction to access the service that provides you with close contact information. So our National Health Service, or Health Service Executive, is the only one in Ireland to use that service. So we're limited to one contact tracing app. Okay, so let's take a look at that contact tracing app. This is the Irish contact tracing app called COVID Tracker from the HSE, the Health Service Executive, and it uses the GAEN, the Google Apple Exposure Notification Service, or the ENS. So the idea is you download the app, and you see here 1,200,000 did. And then when you have a close contact with someone, you get a notification proactively on your screen saying, someone you've been in close contact with over the last 14 days has now tested positive for the virus. You should get tested and we will call you back. The Health Service Executive will call you back. It also gives you interesting breakdowns on the trends in the virus. You can see it happens over the last 2 weeks, last 2 months are all for each county. I've chosen Donegal, so Donegal gets mentioned in 2 talks in this conference. And it even breaks Donegal down by electoral district, which is about 5 districts within each county. You can see the population of Donegal is quite small. It is quite a remote county. So that's the shape of the app. How does it do what it does? Well, after we download the app, say this is me and say this is a friend of mine, we meet and we talk for more than 15 minutes at a distance of less than 2 meters. What happens then is I send them an anonymous key, my details. They send me an anonymous key, my details, and those are kept on our phones. Say 5 days later, this friend of mine gets tested for COVID-19 and is diagnosed as positive. Then she has the choice to upload all her details onto a central server in our Health Service Executive, the HSE. If she chooses to do so, all her anonymous contact keys are stored here, and every night, everyone else's phone checks these to see if they've been in close contact with them for the last 14 days. So my phone looks up here, takes the newly identified COVID positive cases, downloads them to my phone, and compares them to my close contact list that I got 5 days previously, and says, oh, you were close to a person who has subsequently been tested positive for COVID-19, and I will get the alert. So that's the shape of our digital COVID tracing app solution. And you can see how it really prioritizes privacy. No one else can see our data until we test positive. And even then, it's just anonymous keys that other people can download to their phone. Okay, so eventually on to Covigilant itself, the project. We aimed Covigilant at optimizing digital contact tracing apps from 3 perspectives. From the end user perspective, this is vitally important because this close contact alerting system that we're putting in place is absolutely dependent on the number of people who download the app and who retain the app on their phone. So we want to make it very valuable to end users. We want to optimize it from an end user perspective. So we get lots of downloads, lots of retention. So we get lots of contact information. So we get lots of early warnings for everyone. We also want to look at current best practice and see what the best practice in digital contact tracing apps is, and use that to inform what best practice should be. And we want to then take it away from best practice, and we want to see what an idealized solution. So only considering the clinical, social, technical perspective, seeing what an ideal solution might look like. So we have 3 perspectives in our Covigilant project: end users, current practice, and idealized solution. We call them streams. Yeah, so of course I should declare that the work reported on here is not just my work. I'm here, but I'm one of a large team. And that team is not just software orientated, which Lero specializes in, but we also have medical experts on board, like Professor O'Keefe, who's a consultant physician, Dr. Michael Callahan, who's a GP expert in the School of Medicine at the University of Limerick, medical practitioners ranging from both general practice and ICU, so all spectrum of medical practitioners. And we have the odd statistician in there as well, who help us report our results in a reliable, trustworthy, replicable fashion. So I talked about the 3 streams of Covigilant. So stream 1 is the stream focusing on, letting a few people in, sorry. Stream 1 focuses on user perspective. And so we carried out a lot of surveys and that type of work in stream 1. In stream 2, we were focusing on developing an evaluation framework, which will signal to app developers the sort of things their apps should consider when they're designing them, or when they're evolving them after they've initially been deployed even. And stream 3 then was this blue sky idealized solution where we look at clinical, technical, and societal best practice and say, let's not worry about what we can do, let's worry about what we should do. So diving a bit deeper into stream 1, we had we carried out a survey before the digital contact tracing app, the HSE's digital contact tracing app, was even released, to see what the public's pre-perception of digital contact tracing might be. And we were very lucky, we got a huge population in response. We got 8,000 people responding to our request to fill in the survey. While that's a huge number and very representative of the Irish population, it is only so in terms of numbers. Because this survey was, because participation was sought based on internet polls and internet requests, we got maybe a technologically savvy population answering, people with maybe high health literacy and high technical literacy. But we didn't maybe get older people who might be less technological savvy, who don't have internet connections. And of course, older people are a vital cohort here because they are really important in terms of having maybe a poorer prognosis if they catch COVID-19. So we were a bit worried about that, but pleased with our initial survey attempt overall. Then a few months after the app came out, we did a post-app release survey, and we still got about 3,000 people, which is again representative of the entire population of Ireland, 5 million. But this time we were conscious that we didn't really want to leave out the elderly, people with lower health literacy, and people with lower technological literacy. So we identified specific people where we did quantitative in-depth interviews with them to round off our survey. and to get more detailed, in-depth analysis on at-risk groups, for example. We've gathered and analyzed the survey results from the pre-survey and the post-survey, and we have a journal article on the pre-survey, and we've submitted a journal article on the post-survey, but we haven't done the analysis on the qualitative in-depth interviews yet. And we have carried out the interviews, but we haven't done. So I'm now going to just focus on the findings from the survey of the Irish population. So 80% of the people who responded to our survey said that they would download the app when it became available. So that was a real boost for the people developing the app. 95% identified greater than one reason that they wanted to download the app. And it was very community-based. It was, you know, to be responsible to the community around us and try to help the community's health, to help their family, friends, colleagues, and thirdly, to help themselves. But the first two reasons were very community, altruistic type responses. But also 59% had reasons not to download the app. And these were reasons that really centered around data privacy. Specifically, they were worried about what the government would do with the data other than COVID-19, and what the government might do with the data after COVID-19 had passed. Would they really delete it? So they were the main reasons not to. These were the main reasons to. And though I have no evidence to support this, when the minister announced the app was being deployed, he focused on responsibility to the community, helping your family and friends. So maybe one of his speechwriters saw our survey and used that in framing his speech. We're not at all sure. Okay, so what actually happened? So this is pre the survey release or pre the app release. What happened when the app was released? Well, 1.3 million users downloaded and actively used the app. That's about 34% of over 16s in Ireland, the population that were allowed to download it. And it's 38% of people with mobile phones in Ireland. So they're good statistics and generally better than have been achieved in other populations. But of course, we said that 80% would download the app, if you remember down here. And we were able to signal that this 80% was probably an overestimation, because similar work had been done in other jurisdictions who had since put out the app. And they found that maybe a third of the people who said they would actually download the app. And that's sort of what we found here. We found more than a third, maybe 2/5 of the people who said they would download the app actually did download the app. But that's still a very good finding. And when we initially presented our results, we did signal that probably 80% wouldn't. It would probably be closer to 30%. And we were right at 34 to 38%. So there were two other issues, two specific issues to Ireland's contact tracing app that hindered adoption. One was that because we were dependent on Google and Apple for our close contact identification, Apple didn't support the iPhone 6 in the original rollout of that service, that exposure notification service. The iPhone 6 is a very popular phone in Ireland, a very stable, robust phone that people have kept for a long time. And we did a review of the reviews on the Apple Play Store, and we found that 1 in 5 comments about the app was, why can't I download it on my iPhone 6? So we would have expected that this download figure would have been greater if they could have downloaded it on an iPhone 6. Now Apple has made it backward compatible, made the exposure notification service backward compatible. So it does now work on the iPhone 6. So hopefully we will get more users downloading the app. We had another problem as well, in that we had a problem in that those users who downloaded the app noticed that their battery heated up, and the phone heated up and the batteries went down very quickly. And this was actually a problem with the Google exposure notification service, not with the app development at all. Google moved very quickly to fix that over the weekend. But by the time that they had fixed it 2 days later, the damage was done. And in the same review of reviews on the Google Play Store, we found that 1/4 of the users, that a huge proportion of users, about 1/3, noted this as an issue, and 1/4 of those users who reported it said that they were intending to uninstall the app. So we actually noticed a dip of about 200,000 users at one point around that battery issue. So that just shows how important it is to get everything right with the app. So that was the app before, that was the survey before the app was released. The survey after the app released, that gave us a lot of interesting and good findings. Specifically that a lot of people agree that the app was really easy to use. You can see strongly agree is huge here. A lot of people thought that it didn't really deplete their battery too quickly, apart from that one incident, that one weekend. And most people didn't have any problem with the Bluetooth technology that was being used. But a worrying thing from that second survey was that if you add these two columns together, more people are not sure or think that the app isn't helping in our response to COVID-19. So in response to that, the HSE have put more information in the app saying how many people have uploaded their data once they tested positive, and how many people have been notified based on these 5,000 people uploading their data, how many people have been notified that they were close contacts. But there's work to be done there. People aren't convinced that the digital contact tracing app is an improvement or helps in our national fight for COVID-19, limiting the spread. In terms of stream 2, we developed an evaluative framework of concerns, so to identify characteristics that are deemed important in the development of apps so that people will like them, so that they can be stood over in terms of maybe GDPR and stuff like that. And the idea here is to assess or health check existing apps. Have they thought about all the things we've thought about in developing the app? So it's to really prompt designer thinking, both in the initial development of the app and in the subsequent evolution of the app. It ended up being a huge taxonomy based on a bottom-up process where we looked first at individual contact tracing apps and said, oh, what are the important characteristics here? What do they do? We did a parallel academic and grey media literature review of app and health app literature, evaluation papers in specific, to identify what they deemed the important characteristics. And then with all these characteristics, we clustered them into groups, which we call pillars. We assigned each pillar a pillar owner, and that pillar owner had to defend their pillar against the rest of the research team in what we called our devil's advocacy phase. They were specifically asked to justify, well, is there enough attributes in here? Are there enough characteristics in your pillar? Should they really be in your pillar, their location? And are they really relevant, or should they be thrown out, the ones that are in the pillar? Then we applied the resultant framework against the HSE app, our Health Service Executive here in Ireland, and we evaluated the framework then against 4 other contact tracing apps, 2 nationally developed, 2 open sourced, they had a group community development, 2 in Europe and 2 outside Europe, so that they weren't subject to the GDPR legislation. So we tried to make it very general, to sort of stress test our taxonomy or our evaluation framework. I'm just going to give you a brief summary because the taxonomy is huge. We identified 7 pillars, characteristics, which are just general characteristics that help us identify the app rather than evaluate the app. Then its effectiveness or goodness in terms of doing the job it is supposed to do, stopping the spread of COVID-19. Performance in terms of system resources. User autonomy in terms of what the user allows the app to access. Maybe it's Bluetooth, it's GPS. Transparency and how transparent the app is about where the data is stored, what data is stored. Data protection, have measures been taken to make sure that the data isn't vulnerable to attack. And usability, how easy is the thing to use? So I'm going to focus on showing you the structure of the taxonomy and characteristics, and then I'm going to focus on the 3 most important pillars: effectiveness, data protection, and usability. Although usability is so huge, I'm not really going to delve into it. So in terms of the characteristics, you see that there are sub-attributes under that, like availability and organizational reputation. And you'll see that sometimes there are even sub-sub-attributes and sub-sub-attributes. And you'll notice here we get down to a level where each of them is tagged with a precursor like CO5, CO9, for example. And these C's signify that there's an associated question associated with that attribute. So we're assessing that attribute. So here we're asking, is internet connectivity required to access the app? In C09 official documentation, we're asking, is there official documentation available to the app development and design? Where can this official documentation be found? And for those interested, I'm a bit under time pressure, so I won't give you the whole taxonomy, but you can click on that link in the slides. As Maura said, I'm happy that Dr. Sadiq forwards my slides to everyone, and you can see an online version of that survey that you could fill out if you have a contact tracing app of interest even. Okay, so there are other attributes apart from availability and organizational reputation characteristics. There are general characteristics like the name of the application, and their app content. That's a bit hard to read, apologies. Like the sensors employed, what's an overview of its processing. In terms of effectiveness, there are really three categories. This is effectiveness in reporting actual contacts. So basically, does it detect close contacts correctly? Does it identify the hotspots where close contacts are happening with positive cases? This is more national, where we're seeing, is it effective in stopping the spread? Do people share their data once they're detected as positive? How many additional contacts per week does that give us? And the effort in doing that as opposed to manual contact tracing. And this is whether the app is being, adopted. What are the number of downloads, and is it being retained and actively used? In terms of data protection, we look at GDPR because that's very important, and it's probably the state of the art in terms of data protection legislation. So we look at the user's rights, like they should have access to their data. We look at the pillars of GDPR, that data should be minimized, that it should be stored, it should have a purposeful limitation, for example, so it should only be for purpose. And we look at the preliminaries that you have to do to report on these two pillars and rights. You need to know what data is stored, what actions are being taken on that data, etc. So this is typically done first, and then with this data, you can answer questions on the pillars and the rights. We also look at various different security vulnerabilities that the app might have and list those out so people can check if their apps are strong enough or robust enough to avoid those security vulnerabilities. As I mentioned, usability is an absolute huge element of our taxonomy. So I'm not going to go to that in detail, just to say that it looks at things like subjective user satisfaction, design effectiveness, user interaction, how clear that is, universality, is it culturally appropriate for all populations in Ireland, and ongoing app evaluation, is there a feedback loop that tries to make the interactivity more and more. In terms of stream 3, and I'm getting to the end of my time slot now, so I'm just going to give a quick coverage of stream 3. We broke down our considerations in terms of ethical, user experience, technical and clinical considerations. And we came across some fairly generic, fairly obvious conclusions that participation should be voluntary, should be privacy preserving, and there should be no additional functionality. It shouldn't use GPS to track where you are every minute of the day, for example. And it should probably use Bluetooth Low Energy because that's battery saving, and so people don't really notice the drain on their battery. There is the more substantive contributions, I think, from stream 3 are that maybe we should consider a selfish alternative. If you think about the COVID tracing app that we just talked about, what we're talking about there is, you have the illness and you notify others. That's giving to others. Or you're a close contact, you're alerted that you're a close contact, and so you isolate and you go for testing, again, so that others don't catch it. So this is after the fact, after you've caught it or after you've been in a close contact. What if we adopted a selfish perspective where we said, no, the aim should be to try and stop me getting it, me, the user, getting it. I'll buy into an app that does that. So it should be proactive rather than reactive, and rather than being altruistic, it should be selfish. So the idea here is that the app would capture all my close contacts, the people I spend a lot of time with every day, and the people I spend a little time with some days, and it would do exactly the same for those people. And so it would build up a social network of contacts. And then you get to see your social network of contacts. And if people start registering that they're COVID positive with the app, then you'll see how close the COVID COVID-19 is coming to you, how close in your social network it is. If it's 10 degrees away, you don't see these people, they're friends of friends of friends, then that's okay. But once it starts getting closer, and this bar chart is supposed to represent that, the dark red being COVID cases, and you'll see that one of your close contacts is COVID positive, you say, okay, that's when I stop being party going and gregarious, and I start getting more withdrawn and not meet people. Now, the advantage there is that you don't get the virus in the first place. You adopt your behavior before it gets to you. But we don't even need to go that far. We could have nudging behavior where, you know, we report on the number of close contacts you've got every day. This can be done on the phone with no data protection implications. Oh, did you know you had 5 close contacts today? Or did you know that for the 10th day in a row, you've had less than 2 close contacts? Well done. That's that idea of gamification streaks, where you keep going on a certain behavior, a streak for so long. And that reinforces someone saying, well done on minimizing your close contacts. Actually feeds into people's behavior and stops them from meeting close contacts. In terms of effectiveness, we really need to put a non-app thing in place, which is what prompted you to get tested today. When people go for COVID-19 testing, we need to ask them whether it's symptom-based or whether they got an alert on their app, because only then can we know how much the app is feeding into the national effort in restraining the spread of the virus. We also noticed that ultra-high band or ultrasound is better in terms of accuracy in detecting close contacts. So we're, at the moment, we're indebted to Google and Apple, but maybe we should move beyond that to try and figure out close contacts. I have a lot of screen captures on my presentation today, and that's good for the presentation, but not so good for privacy. So maybe we shouldn't be allowed to screen capture. We should, of course, notify people in Ireland that the app is now iPhone 6 possible. So that more or less finishes it off. I just want to say that Maurice had a nice photo at the end of his presentation showing the group that were working on the app, on his research project. This project, of course, started after COVID-19, so we were spread all over the place. So we had a really tough working situation where we had a big taxonomy and a huge spreadsheet up here, and we were all trying to discuss it over the web. So I can't wait to get back to a situation where we collaborate face-to-face on a whiteboard. So that's just my parting COVID-19 thought. I hope that happens soon and that people can be safer and meet more soon. I'll leave you with a list of the publications we've had from the project so far: 2 journal publications, 2 conference presentations, and we have 3 other journal articles in preparation. And of course, much more important than each of this, we've always given our results and output to our Irish Health Service Executive and Department of Health much before we publish them, because we think that's the important goal in this project, really, to try and help the national effort. So that's it. If you have any questions, I'm happy to take them via chat or via Dr. Sadiq.
Thank you, Jim, for a nice presentation. And we have one question from the audience that about the percentage of positive cases updating their data on the app and those who do not, as it could be a challenge.
Yes, so if we just go back to that slide where I talked about the structure of our app, the problem with the structuring of the app is that we only get the uploads that are uploaded. And we don't get the people, we don't have any insight on the people who don't upload the app. Likewise, you know, if we gathered more information centrally, we could do more epidemiological studies. But yes, that's a core problem for us as well. We don't know how many people what proportion of people who are tested COVID positive do upload their data, and the proportion of people who don't upload their data. We don't know so much more because we have this heightened data protection issue. In fact, if you consider Novid isn't adherent to GDPR legislation either, so we can't gather the social network information, because you can imagine how with social network information you can if you have enough data, you can de-anonymize the data, or you could potentially de-anonymize the data. So GDPR doesn't allow us to use this selfish alternative yet. Yeah, it's definitely a challenge. Good question.
Another question we have that is something on the false negative and false positive cases of your app. Any data on it?
Yeah, so that's another really good question. So one of the problems is that people live in apartment blocks, and you can be at your kitchen table, and a wall can be beside you, and on the other side, other people can be at their kitchen table, so they can be within 2 meters of you for greater than 15 minutes as you both have dinner. But of course, there's no transmission there because there's a wall between you. But they will give us false positives, false positive close contacts. I'm not aware of any study that says how accurate the gain and the Apple Google exposure notification service is, if it is actually accurate, 2 meters and greater than 15 minutes. Because Bluetooth Low Energy is very dependent on your model of phone. Different phones talk at different strengths of Bluetooth. It's very dependent on whether your phone is in your pocket facing the person, or if it's in your back pocket, which is not facing the person, and likewise their phone. So it's a rough proxy measure. And yes, there are false negatives and false positives there that we need to be very aware of. I suspect that they err on the false positive side, that they give people more notifications than they should. But of course, this means that you get your 10th notification, and the previous 9, you tested negative, and you're going, another notification, and you ignore it. Yeah, so there's another question on chat there which says, is the distance of 2 meters between users or their mobile phones? It's between the mobile phones, and that's so if they're sitting apart and their cell phones are nearby, that's another inaccuracy. It's not perfect. I suppose the way our digital contact tracing app effort has been contextualized is contact tracing is important, and 2 important components of that are the manual contact tracing and digital contact tracing. Neither is perfect. Manual contact tracing, you don't get the people you've been close to but don't know, for example. You're prone to memory recollection faults, so you don't remember all the people you had contacted with, but you're pointing out some of the problems with the digital contact tracing app solution as well, which addresses those other 2 problems. So we have both in Ireland. We have manual phone contact tracers who will ring up the person and say, can you take me through the last day, the last 14 days of your contacts? But we also have the digital contact tracing app, and everyone goes through manual contact tracing. And if they have downloaded the app and are willing to upload their data, digital contact tracing. The biosecurity of this data, I think it's a very secure solution. It's sort of best to breed in terms of how secure it is. Like, the only thing that gets uploaded to anything central is your keys for the last 14 days, so that other users can look, see the new COVID cases, download the keys and compare them to anyone they've talked to. But it's an anonymous contact key, so they don't know who you are at all. The only subtle security risk of this is that, of course, Google and Apple have written the operating system for your phone. So this data, your anonymous contact details, is stored on your phone, and it's not secure to Google and Apple. Now, I'm sure Google and Apple act very responsibly in terms of what they do with that data, but ultimately it's not secure to Google and Apple.
Okay, thank you, Jim.
Okay, thank you very much, Dr. Sadiq.
Hopefully, we will meet very soon physically.
Hopefully.
Hopefully.
To a better day.
Our next speaker is Professor Andrew Weir. Andrew is Professor of Computing at the University of South Wales in the United Kingdom. His research interest centers on the use of intelligent computer system, artificial intelligence, and data science-oriented solutions to help solve real-world problems. Professor Andrew is currently working on AI-related projects with several industrial and commercial partners that include Tata Steel, National Health Service, Wales Informatics Service, and Y Education. In addition, Andrew is the director of Aurora International Consulting Limited, an innovative software as a service company that provides AI-enabled review software to the construction industry. Andrew is also a director of research for the Welsh Institute of Digital Information, a collaboration between University of South Wales, University of Wales Trinity St. David, and the NHS Wales Informatics Services. Furthermore, Andrew is a regional director of Techno Campus, an innovative and ambitious project that seeks to engage young people with computing and its cognate subjects. Andrew is editor-in-chief of the journal Annals of Emerging Technologies in Computing. So now over to Professor Andrew Weir.
Hi, thanks very much. It's nice to be here this afternoon. The talk I'm going to give is quite different to the previous two talks in that I'm going to, in a sense, talk on a non-technical level about really a personal impact statement about what COVID has meant, and maybe look at some wider learnings from that. One of the things that I've been able to do during COVID is I've had more time because I've spent more time at home, spent significant less time traveling, is to do a lot of reading. And one of the books that I've read, again, I read it in school as a young boy, but one of the books I've read again is A Tale of Two Cities. And that starts off with a line, "It was the best of times and it was the worst of times." And really, when we think back over the last, or when I think back over the last 13 months since COVID started, it has been the worst of times, without a doubt, but in many ways it has been the best of times. If I think about the UK in particular, it's been a great coming together in a way that maybe we've not seen in recent decades. Where, for example, at the beginning of COVID, every Thursday night, the whole population almost would come to a stop and go out and stand on the streets and clap to give applause and give thanks to the National Health Service for the hugely impactful way that they've been fighting COVID. And yet, well, we've also seen masses of people die. We've seen coffins lined up waiting for funerals in a way that we've not seen since the Second World War. In the UK, 130,000 people have died because of COVID. So it's been a dramatic time. It's been a time which has been very, very strange, but it's also been a time where people have come together and have learnt in a way that was previously unimagined. One of the quotes I've liked is that pain teaches you more than pleasure, and failure teaches you more than success, poverty teaches you more than prosperity, and adversity teaches you more than comfort. Basically saying that hard times can actually be times of learning. Now, the previous two speakers that we've had live in Ireland, and if you look at that map, Ireland is to the left of the United Kingdom. The United Kingdom consists of four countries: Northern Ireland, Scotland, Wales, and England. And Wales is to the left of England. And on that map, I live in a little place called Skewin, which is near Neath, which is marked by point A. And I work in a place called Pontypridd, which is marked by point B. Now, every morning I travel on work days from A to B. That journey can take between 50 and 90 minutes, really, depending on traffic and things like that. So it's not an insignificant journey. Since COVID, for the last 55 weeks, on the 16th of March, 1920, I was on my way home from work, and the Prime Minister announced that we should, if we could work from home, we should work from home. The university made a decision that night that everything from then on would be online. And so for the last 55 weeks, I've worked from home. I've not been to campus for 55 weeks, and it's not just me. A huge proportion of the population has moved from working in offices, traveling and commuting every day, to now being based at home. Now, my savings in terms of fuel has been significant. If you do an estimate that it costs me £8 a day to travel to work in fuel, and that's a conservative estimate, and you multiply that by the number of days and you multiply that by the number of weeks, I've saved approximately £2,200 just on fuel costs in the time of COVID. Not only have I saved on fuel time, but I've also saved on time in that travel. Now, I think going forward, the way that the university is going to work, the way that society is going to work, is that there'll be a far less demand on people going to the office. We've become very adept at using technology to communicate. I have visited your campus previously on 2 occasions. I've met many of you. I'm friends with some of you. And now we're doing this online. And I think that's a learning and a change that, as Jim just said, it'd be lovely to get together again with friends and family and colleagues and things like that. But there's also, I think, going forward, going to be a significant shift forever in the way that we do things. And just thinking about myself, being selfish for a moment, I work on average 45 weeks a year. If I was to save going into the office 2 days a week, so I worked in the office 3 days a week and from home 2 days a week, going forward, I would save each academic year £720, a significant saving going forward. Not only have I saved on fuel, but I've saved a significant amount of time. If you look again over the last 55 weeks, I've been working at home rather than going to the office. Going into the office requires a journey into work and a journey coming home. So about 100 minutes every day sat in the car on average. You multiply that up, and over the last year and a bit, I've saved approximately 51 working days. A significant amount of time. Again, going forward, if I was to reduce the number of times that I went to the office just by 2 days a week and multiplied that up over the period, you'd see that I'd be saving approximately 16 working days a year. But it's not all savings, though. The UK government estimates that already COVID has cost about £18,000 per working person, and that amount of money is rising rapidly as vaccine rollouts and various other programs kick in. So there's been a saving to me as an individual, but in terms of government spend, there has been a huge cost. And in the UK, as in most other countries, the way that that cost is actually met over a period of time is through increased taxations. And so if you take that kind of estimate about that £18,000 that it's cost, you take the £720 that I'm saving per year on fuel bills, it's going to cost, if everybody was, if I'm Mr. Average, then it's going to cost, take another 25 years from the end of COVID to actually make right that deficit. And by the time we get to the end of COVID, I would imagine that 18,000 will have been significantly increased. And I'm not the only one. The UK has many good things, but one of the things that it has is a relatively poor infrastructure in terms of traffic. This is a picture from a tube station in London, the capital city of England, the centre really of where a lot of the economic activity goes on in the UK. And every morning, every evening, you will see hundreds and thousands of people cramming into trains, travelling underground to go from home to work. Many of these people work for companies that now have discovered that most of the work that they've been travelling to the office to do, they can actually do at home. Why on earth would they want to travel every single day from the place that they live to the place that they work, squashed into a tube traveling underground. And so lots of companies have discovered that they can attract staff, they can give them more meaningful contracts, they can give them a more meaningful work-life balance by getting them to work part of their time at home, travel less, enjoy life more, and change not just the impact on them, but the impact on the environment. It has changed the way that we work. It changed the way that we live. It changed the way that we do things. Things that have changed, other things that have changed due to COVID. In the UK, we have a good system of where we're able to go and see our doctors, what we call our general practitioner doctors, the local doctors, and a hospital system. In the last 13 months, the way that we've interacted with medicine and with medics has changed significantly. The man that's currently in charge of the health system in the UK has said that he hopes that going forward, that the vast majority of consultations with GPs will be remote, that they'll be online. It'll save people traveling to see their doctor. It will save people having to queue to see their doctor. It will mean that doctors will have far more flexibility in the way that they do things. Now, there are concerns, you know, that this moving online isn't a panacea to everybody's problems. It's not going to sort out every need within the National Health Service within the UK. It's not going to sort out the problems globally, but certainly it will have a significant impact on the way that health services actually work and function. Now, as I said, this is a bit of a personal reflection rather than a technical talk. And this picture is of me and my father. My father is 87. And even though he's in reasonably good health, he does have a number of issues. In later life, he has developed diabetes. He's had a number of cancers that have needed to be treated. And in the last couple of years, he has had a number of cancers appear on his skin. Typically, what happens when a cancerous lump develops on his skin, we make an appointment to go and see his GP, his general practitioner in the local doctor's surgery. The doctor will examine it. The doctor will have his secretary or her secretary write a letter to the hospital. The hospital will have a consultant that will look at the letter from the GP. He will then write to my father, requesting that my father come in for an examination by the consultant. The consultant will examine the cancer, and then he will make an appointment for my father to go and have that cancerous growth removed. That was post-COVID or pre-COVID. Since the start of COVID, my father has had 2 lumps. On both occasions, we have phoned the GP. The GP has asked that we send the GP an image of the growth area, which we've done. The GP has looked at it and has forwarded it to the hospital. The consultant has had a look at it and come to a conclusion. And then the consultant has written to my father, asking him to go into the hospital at a very specific time. My father has turned up at that very specific time. And on both occasions, within 25 minutes, my father has had an injection to kill the pain. He's had the growth removed, and we've been on our way home. A process that has required many interactions and many points of pain within that chain, lots of delays, have now been obliterated. The process has become far more seamless and straightforward. And going forward, it's very likely that while not all GP appointments, while not all referrals to consultants in hospitals will be that quick, that going forward, things will have changed forever. COVID has had a hugely negative impact on the number of people that have been ill, the number of people that have died, but it also has had an acceleration in the way that we've used technology to facilitate good healthcare. Now, one of the research areas that I'm very involved in is the use of data and big data. Again, what has happened in our use of data is that the last speaker, Jim, mentioned the GDPR, and lots of people used to use the GDPR as an excuse for not sharing data, for not using data, and would read into the legislation things that weren't there. COVID has required that we accelerate the way that we do things. And by accelerating the way that we do things, it's meant that we now have access to data, which we would have got previously, but had to jump through almost endless hoops to get that data. Now things have been abridged, and ways of achieving what we needed to achieve have been accelerated. And we now have access to data which previously we didn't have access. Again, COVID has acted as an accelerator to bring about the change that was so much needed. Something else that has come to light regarding COVID is that some of our data isn't as good as we thought it was. Now, a lot of the work that I've been involved in is to do with machine learning, and machine learning, in essence, as most of you probably know, is rather than writing algorithms that analyze every nuance of the data, actually learn patterns from the data. I did my PhD a long time ago in robotics, and my PhD basically would be consigned to the history department now. It was to do with getting a robot to move around a very simple environment using very simple black and white cameras. And really what was happening is that we had if then else rules that would modify themselves as the thing learned. If then this happens, then do such and such. And you can imagine that anything that was very complicated or even basic required so many lines of code that it became really quite complicated quite quickly. Now we have systems where we have, we're at the point where we have self-driving cars, and there aren't millions of if-then-else rules in the software that drives those cars. But what there are is complex mathematical models that have been trained and adapted using the data. And so a lot of the systems that we have are based on data. And said one of the things that's been highlighted during COVID is that some of the data that we've got is not all we thought it was. So when we're building machine learning, what do we have? We have features from that data, and we repeatedly learn models. Now, one of the catastrophes that has been in the UK was over examinations, and I'll come on to speak about that in a little while. But something else that has been impacted because of COVID is the way that we teach, the way that we interact. As I said, on the 16th of March last year, driving home, listening to the radio, Boris Johnson, our Prime Minister, made a statement about people working from home. That evening, the Vice-Chancellor and a senior executive team made a decision that we would be moving online from that evening. As a university, we had a virtual learning environment, but we were certainly not in any way a university that fully understood and fully grasped what e-learning was all about. In common with many, many other universities, we had to learn fast. We had to adapt fast. We had to have systems in place. We had to have processes in place to move our learning from a traditional classroom, a lab-based situation, to working at home. And again, I think I can't wait to get back to the classroom to be able to talk to students in person. But I think the way that we teach will never be the same. We have students now who are very happy to have lectures that are pre-recorded. They can look at the questions at home, they can look at the lectures at home, and then they can come to our online tutorials with questions already to be answered. And I would imagine going forward that the students will continue in many disciplines to have pre-recorded lectures online that they can watch at their own leisure, at their own time, in their own location, that they can work through the questions that they have, and then they can come to a face-to-face tutorial to actually interact and to discuss and to talk through that kind of lecture. And I know that this idea of a flipped classroom where students do part of their work at home before coming to the lecture is not a new idea. But certainly it's new in the way that the number of universities are now practicing it. Things have changed significantly. There is a paper which one of my friends, Tom Crick, is one of the co-authors, and it talks about COVID-19 and digital disruption in UK universities, afflictions and affordances of emergency online migration, talking about some of the learning that we've had as we've moved overnight from a traditional face-to-face system to working online. The impact was quick and the impact will be long-lasting. Other things that have changed for me. Before COVID, I had never used Zoom. To be honest, I'm not sure even if I'd ever heard of Zoom. Now, 13 months after the start of COVID, happy to give lectures, happy to give tutorials, happy to speak at an international conference using Zoom. Before lockdown, I would regularly travel to Cardiff, London, and elsewhere for very short meetings, typically less than 2 hours. And I would spend more time and more money traveling than actually time in the meeting. My research students have become far more proficient at online collaboration. And I'm glad to have a PhD student in Pakistan working remotely. It's been a revelation working online and collaboratively. The companies and businesses with which I work have become online. One of the companies that I work for is a school called Way Education, or a company called Way Education that has a school in Dubai, which is an online comprehensive school in the UK. It has nearly 3,000 children working at home, and they've worked at home as an online school for many years. And the teachers have worked at home for many years. But they had offices in Crickhowell in parts of Wales. And the staff that were there, the support staff, were all based in the offices in Crickhowell. When people were appointed, they moved to Crickhowell to work. Since COVID, they've changed their policy. Staff no longer need to relocate to Crickhowell to work. And it's had a revolutionary impact on the geography from where they've been able to appoint staff. In a sense, the world has become a very global village, and the locality has become far less important. I've done my first PhD viva with Microsoft Teams. I've acted as external in Singapore without actually flying there. Things have changed. For many, COVID-19 has made the world a smaller and more interconnected place, a global village. But what it's highlighted is the things that we need to invest in. We need more bandwidth, not more road width necessarily. As I said, in the UK, we have a traffic congestion problem in most of our major cities, where post or pre-COVID, the roads would be jam-packed with cars in the morning rush hour and in the evening rush hour. Now people have moved online. A lot of that congestion has disappeared. But we've found that people have struggled with bandwidth. At the start of COVID, I had to upgrade our home's broadband capability because It just couldn't cope with people working from home consistently and constantly every day. And so we had to upgrade, we had to invest money into making things work. And not just as individuals and as families, but going forward, I think governments need to consider investing more in bandwidth rather than road width. COVID-19 has taught me that in adversity, it can bring opportunity. It's been a learning experience about how to do things differently. A survey has said that 60% want to stay at home, home working after COVID. Many companies are downsizing their footprint. It allows them to save money on building space. It allows them to save money on energy. It allows them to give staff and to attract better staff by giving them a better work-life balance. The change has been phenomenal, and the change is, as I said, permanent and long-lasting. Working at home has caused a lot of problems for a lot of people, particularly, I can only talk about the UK, where when schools have been closed and parents have had to not only work at home, but educate their children at home. That has caused huge issues. We've seen, I've had colleagues trying to give lectures with babies crying on their laps. It hasn't been ideal, but going forward, as schools reopen, as society gets a little bit back to normal, then hanging on to the positive learnings while mitigating the things that are probably not so good is the best approach. Coming down the track is a problem that is likely to be much more significant than COVID. And that is the whole issue to do with global warming, destroying the planet. And we've seen during COVID that we've been able to work as nations together to make sure things work in a way that is effective and ameliorate some of the problems. And hopefully, as we build back from COVID, we will build back, as the mantra goes, build back not just bigger, but build back better. COVID has changed things. As I said, going back to education online, one of the fiascos that happened in the UK is that the government decided that because schools were closed, because children and pupils couldn't have exams, that what they would do is that they would predict the exam results that children would have had. And it caused absolute chaos. It caused chaos for the universities who had students applying, and the grades were obviously very different to what we'd expected them to be. And at the end of the day, the government had to backtrack and say that the algorithms that they were using, that the data that they were using had many flaws, and to backtrack. And so going forward, as we move into a digital world that is even more digitized and more connected than previous, then we need to make sure that the way that we gather data, the way that we use data is correct, that we don't end up with situations where people are disadvantaged because of their lack of cognitivity and their lack of understanding of what the data can do. COVID-19 has given many new opportunities. It has shortened the timeline from idea to implementation. We've seen that with the vaccine that's being rolled out at a phenomenal rate. It has made collaboration easier. Most of us are now more relaxed about working online. It has made research and innovation even more important, and no more so than in health informatics. It has been a wake-up call about the impending issues such as global warming. COVID-19 has changed things. The question we need to ask maybe of ourselves is, how has it changed us? Intelligence is the ability to adapt to change. And that's a quote from Steve Hawkins. And from Charles Darwin, another quote: "It is not the strongest of the species that survive, nor the most intelligent that survive. It is the one that is able to adapt to change." And as we reflect on the last 13 months of COVID, the impact that it has had, the question we need to ask is, what have we learned? How have we changed? What is different? Can I say thanks for listening? It's been nice to be with you this afternoon. It's the morning in Wales, and I hope that one day in the future to be able to visit you again in person. But for today, thanks for listening.
Thank you, Andrew, for a nice presentation and very informative talk. Our next speaker is Dr. Wasfa William. He is serving as a senior lecturer at Marlborough University of Science and Technology in the Department of Biomedical Sciences and Engineering. He is the head of the Department of Biomedical Sciences and Engineering and leads the Advanced Medical
Dr. Khan, your mic is mute. Unmute your mic.
Thank you, Andrew, for your nice presentation. Our next speaker is Dr. Wasfa William. Dr. Wasfa is serving as a senior lecturer at Marlborough University of Science and Technology in the Department of Biomedical Sciences and Engineering. He is the head of Department of Biomedical Sciences and Engineering and leads the Advanced Medical Imaging and AI Lab in the Department of Biomedical Sciences and Engineering. Furthermore, he is a member of Marlborough University's Quality Assurance Committee and Research Ethics Committee, the CEO of Global Auto System Limited, Uganda, a startup revolutionizing service delivery with use of AI, data analytics, blockchain, and robotics. His research interests include the application of AI, machine learning, modeling and simulation, and data science in health, agriculture, business, education to improve service delivery in low and middle income countries. His title of the talk is Digital Health in the Era of COVID-19, PAP's AI Use Case in Uganda. So over to Dr. Wasfa William.
Thank you so much, Dr. Sadiq, for the introduction. And I really welcome everyone for this session. I'll share my screen now.
Yes, please. Can you move to the slideshow mode? Yes, perfect.
Okay, so thank you so much. So my talk will be a brief talk about digital health in the era of COVID-19. And I will give a use case of PAP's AI in Uganda. So despite the fact that the adoption of e-health is still low in Africa, the COVID-19 pandemic has really led to a shift from traditional medicine to one that's adopting Health 2.0, which is basically digital health. Yeah, from a recent study that was conducted by WHO, of which I participated, we have developed a global technological innovations database, which is available at innov.afro.inc. And we observed that actually during the COVID-19 pandemic, a lot of innovations were unleashed. However, most of these innovations were ICT driven, and these innovations were used in different response areas like risk communications. And in risk communications, you observed a lot of innovations like SMS-enabled custom mobile applications, social media blogs, web-based platforms to really facilitate the risk communications and also improve health. We also observed a lot of innovations that were enforcing social distancing innovations. Some of these were e-health applications. And from the research that we were published, we have observed that actually a lot of these innovations were digital health, though most of the innovations are coming in from North America, from America, India. But we also observed that Africa was adopting these digital technologies. So that brings me to my major discussion for this session, which is PAPS AI. So PAPS AI is an innovation that I've worked on for almost the last 5 years. It emerged from my PhD research, which I worked on with supervision from different experts, including Professor Andrew Warrior, who just presented, the recent presenter. So PAPS AI is a series of hardware and AI-powered software innovation that makes cervical cancer diagnosis and patient record management more faster and more efficient. It's really very, very important and useful in the era of COVID-19. So it consists of a local 3D printed digital microscope size scanner and a digital oncology information management system. Why did I venture into this PAPS AI innovation? So cervical cancer globally ranks as the 4th most prevalent type of cancer, with over 500 women diagnosed with this disease in 2020. So patients' follow-up became disrupted during the COVID-19 pandemic, especially where we had lockdowns like in Uganda. We have Uganda's Cervical Cancer Institute or Uganda Cancer Institute, where we find over 100 patients every day. During this COVID-19, with the COVID-19 restrictions, we would actually not find any patients at these cancer units. So the highest instances of cervical cancer occur in low and middle-income countries, with 80% of these instances occurring in Africa. Uganda is ranked 14th globally and 7th in Africa, with the highest instances of cervical cancer. And unfortunately, 85% of those diagnosed with cervical cancer die in Africa. And this is attributed to late-stage diagnosis and misdiagnosis. However, cervical cancer can be prevented if diagnosed at an early stage. And pap smear is the commonest and regular approach used in Africa. But this approach is time-consuming, laborious, and error-prone. It is subjective and inconsistent, as hundreds of sub-images have to be analyzed under a microscope by a trained cytopathologist, who are also very few in low and middle-income countries. The available digital microscopes that can provide automated diagnosis are very expensive, and these have had limited impact in low and middle-income countries. The commonest low-cost microscopes that are available are manual, have limited capability of digitizing these images, and also risk factors assessment is not fully incorporated into the cervical cancer screening. Also, patient information is not centrally stored, so it is easy. It's really hard to follow up these patients and also have telemedicine support, especially the fact that we have few experts that are in few regions. So you find that somebody has to manually move from the western part of Uganda to the eastern part of Uganda to deliver these complicated slides to experts, which is also time consuming. So our solution is PAPS AI. PAPS AI is actually adding artificial intelligence to pap smear analysis. It has evolved from PAPS. It started from PAT. It was just a pap smear analysis tool. Then it evolved to PAP ES. If you read about our papers, some papers have PAP ES, which was a pap smear expert system. But now we have improved it to PAPS AI using the data set you have been collecting using our microscope. So we have developed an AI-powered digital health platform with an automated low-cost digital microscope side scanner, an automated pap smear analysis tool, and an automated cervical cancer risk factors evaluation, which we call the cervical cancer risk factors evaluation engine, and an integrated cervical cancer patients information management system with clinical decision support and picture archive communication. So the integrated information management system, we have dubbed it, or we call it ONSIMS, which has teleradiography with both manual and automated pap smear analysis tool. So this is the dashboard for our integrated information management system, where we keep track of patients' information, protocols when we are capturing patients' information. We develop or we design the health worker develops protocols like CAF protocols, which can be assigned to the patients, and all this process has been automated. We manage referrals from one hospital or from one center to another one, and also telemedicine support is incorporated into the platform. So our platform also captures meetings, especially tumor body meetings for every patient or for every patient, so that now junior staff can always learn from decisions that were made on similar cases. So our platform also provides imaging. This is the imaging part. So initially the imaging part was a separate tool attached to the microscope, but now we have incorporated it into our online platform with both manual and automated image analysis. So the microscope is a low-cost digital microscope size scanner, which is 3D printed. It actually costs around 700 USD, which is 4 times cheaper than commercial microscopes like Olympus, the multi Olympus, which is commonly used. It consists of 3D printed parts. It has an objective lens from the existing cameras and just a stage, which is automated, driven by stepper motors. So these are just the 3D printed parts. We developed it using Rhinoceros 3D software, and now we have been able to 3D print a number of these type of microscopes, which are actually being used for, they are in clinical trials now, but the microscope is being used in nursing institutions where they're using it to train nurses how to actually observe and diagnose pap smears. So we also have a static cancer factors assessment. So our platform has a tool where the clinicians during data collecting asks the patient a few questions, and the platform can automatically provide an assessment whether this person is at risk of having cervical cancer or not. And we have used the physiologic model, and we have evaluated this with now 100% correlation between what our expert system provides and expert judgment from the patients. So we have also done rigorous assessment for our analysis tool on series of data sets. One is full site test images, and our platform has been able to provide an overall accuracy of over 97%, sensitivity and specificity of 98 and 97 respectively. We have also tested it on 60 pathology slides from a cancer clinic, and we have been able to get an accuracy of 95% on this data set. So this PAPS AI has also been recognized internationally. For example, it was among the finalists, the finalists for the 2020 Africa Prize for Engineering Innovation by the Royal Academy of Engineering. It was also shortlisted among the top 30 innovations from Africa by WHO. And also the innovation showcased at the Commonwealth Health Ministers meeting in Geneva. And we have partners, like you said, has supported the implementation of this platform currently at Imbara General Referral Hospital, and the Royal Academy of Engineering through the grant we received. We're also implementing this project at Imbara General Referral Hospital, and we have published a number of papers from this work during the PhD research. And I thank you so much for your time. Thank you so much.
Yes, thank you, Dr. Waspa. I think we should check any questions. I think one question that is for Andrew. Andrew, you are here?
Yes.
What is the data sharing policy for research purposes?
In the UK, there are quite strict rules and regulations about the sharing of data, but due to COVID, a lot of the processes in getting the approval have been shortened, but there are still rules and regulations, and we still need to follow the GDPR regulations, which are in force across Europe. So the use of personal data is strictly controlled, but the processes for actually getting approval have, in many ways, become shortened.
Okay. So we request to the participant to stay connected for just 5 minutes. After 5 minutes, we resume our concluding session there. Just for 5 minutes. Okay, thank you for your patience to all the participants and speakers. So today we have a very wonderful session. Dr. Morris Molvino is talking about digital app chatbot, clustering of call data, pre-COVID-19 or active COVID-19 behavior. He's talking about developing a stakeholder-centered digital health model for the mental health there. Professor Jim Buckley has talked about the constraint in the European Union, co-vigilant app there. He's talking about qualitative in-depth interviews, statistics about the deviation process, and characteristics, illustrative structuring, data protection, and its usability. Professor Andrew Weir, he talked about things that affects due to COVID-19 and about big data and machine learning. And before COVID, that we didn't use so much technology for the education there. So we need bandwidth, not more the road there. And Dr. Wasfa William, he talked about PAPS AI, that about cervical cancer diagnosis there, risk factor analysis, and he developed artificial intelligence powered digital health platform. And he uses image analysis for recognition and pattern there. So I'm really thankful to all the speakers. First of all, we would like to give a token of appreciation to our honorable chief guest. This is Professor Dr. Bhavani Shankar Chaudhary. We will send you, sir, physically. And next, our guest of honor, Professor Dr. Bhavani Shankar Chaudhary. Next, we present a token of appreciation to our beloved Professor Dr. Muhammad Iqbal Chaudhary. Next, token of appreciation for Haris Ikram. He is program manager at Comstech for his valuable time. Thanks, Haris. Next, we want to share a token of appreciation to our honorable speakers, Professor Andrew Weir, Professor Jim Buckley, Dr. Waspa, and Dr. Morris. So it is our indeed honor that a personality we have in this our closing session as a guest of honor, Dr. Shahab Imam. He's the son of Professor Dr. Mumtazul Imam. Professor Dr. Mumtazul Imam is our mentor He's our teacher. We learned a lot from him. May Allah bless him. Dr. Shah Imam done his Bachelor of Medicine and Bachelor of Surgery in 1992, then done the Bachelor of Arts, and then moved towards further towards the education journey as a Bachelor of Law and then Master of Law. And he served, he qualified Sindh Public Service Commission examination for medical officer held in 1993, and then qualified CSS exam in 1994 and allocated to Office Management Group. Then he qualified CSS Federal Public Service Commission Central Superior Service Examination in 1999 and allocated to Customs and Excise Group. He served as an additional collector exports, as additional collector imports, as additional collector law for imports and export, and as deputy collector imports and as deputy collector exports as well. So as he served in the government service as a long journey, and after premature retirement, after 25 years of his valuable services, now he moved towards the law. Now he's doing advocate. So we are very thankful to you, sir, to be here and give your precious time. So I would like to invite you to say a few words.
It is a matter of great honor that I am representing, rather I am here on behalf of my beloved father, Professor Dr. Untitled Chapter, who has scooped in the pandemic. He did his PhD way back in 1966 from London University. And then he did his PhD, a postdoctorate from Italy. And he served in the Department of Basic Sciences in Mehran University, Sindh University, and he retired from Mehran University in 1998. Then he moved to Karachi and he joined National University to FAST. He served there for 7 years, and in 2005 he joined Sir Syed University, and till his death he was professor and chairman of computer science over there. So throughout and he died at the age of 82 years, and all his life he served in Pakistan. He served in the education department, and he never switched over to any administrative assignment because teaching was his passion. And I was asked by Dr. Sadiq to come and grace this occasion. And this is a matter of great privilege for me to be here among the youngsters, among the hope of this country, among you are the torch bearer of the coming times. And the only way to success is hard work, and you should be knowing your job properly. Currently, we are facing the shortage of jobs in government and public sector, especially for the students who live in Karachi or who live in the urban centers of this province. But that is not an element of any dismorality. You don't have to be demoralized yourself, because if you are competent, there are so many ways. This is an age of technology. This is an age of innovation. Master yourself on that, on the cutting edge technologies. Pakistan is way behind the proper educational system. So you can, in this world of information, in this world of vast knowledge, when we did CSS, there was no internet, and we didn't have any access to the volume of knowledge, the volume of books which this generation do have. So work hard, work day in and day out, public service or the public sector services is not the end. You have the whole world in front of you. And if you are competent, no one can stop you. If someone stops you at one place, you will be having a better place somewhere else. So the only key, the only ingredients to break the cycle of poverty is education. My grandfather, when my grandfather died, my father was only 12 years old. And my grandmother died when he was only 8 years old. He had no one to support him. He was all alone. But he did his PhD because of his hard work. So don't be discouraged, because no matter you have your father, you don't have your grandfather, but because of hard work, he did his PhD and he was a successful man. Thank you.
Thank you, Dr. Shah. Because your journey is a role model for young students especially. So on the behalf of the comstech and IEEE Karachi section, I would like to thank to all the participants, especially all the speakers, to be a part of this international one-day seminar. So hope to see you again in coming future. And physically, we will meet inshallah by the end of this year. Thank you. Thank you for all.